All right, here is your Capstone Weeks 3 and 4 overview based off of your slides that you gave me. As usual, I'm just going to narrate over it and see if there's any hot spots or points that I know is a pattern of behavior when it comes to asking certain types of questions about these certain types of topics. And if you forget anything, I'll add that along as well. Note that this is going to be one shot, one kill, which means I will not be editing these. I have DuckTales on in the background. Athena is here running rampant, so crashes and booms, beware, it's going to be a thing. And life is going to be peachy, and we're going to do great on this exam because you guys are fully prepared and you've worked together, and I am so incredibly proud of you and I love you so much. So yeah, let's do this. Okay, 1, 2, 3, go. Okay, first off, whoever did this slide, bravo. This is a beautiful slide. Not only is it a beautiful slide because you put some nifty pictures in there and made it interesting, right? However, the bigger deal is that you put every scope and scale you're going to need for every question related to this. So here's what I know. I know we love to ask this question on standardized tests, exit HESEs, NCLEX is going to be on there. They usually ask about 3 things. Number 1, they're going to ask you to associate what degree burn with this presentation. So it's not going to say superficial partial thickness for first degree. It's going to say that skin appears to be red and swollen and inflamed, with no underlying cuts or abrasions or lesions, right? It's going to let you know it's just on the top, but it's not going to say superficial partial thickness. That's scenario number 1. So you need to know first degree burn means what is the presentation physically of that burn? What is it doing immediately after exposure? Number 2 scenario. Number 2 scenario is I have a patient who is burned on the abdomen, anterior only, the groin, and the left leg in its entirety, so anterior and posteriorly. What is the percentage of the burn? That's scenario number 2. It's absolutely going to happen. I'm willing to bet me making you guys dinner on it, and it'll be a good dinner. I'm that confident you're going to get one of these 3 questions. All right, and then number 3 is kind of an easy one. They want you to associate the depth of the tissue with the degree of the burn. So epidermis, dermis, hypodermis, that type of a deal. So it's going to say patient presents with full thickness burn, exposing fat, muscle, and bone. Rate the degree. Okay? So either way, you need to know, whoever put this remarkable picture right here, let me use my little pointer, whoever put this remarkable picture right here, and whoever was smart enough to put this remarkable picture right here, that genius right there just saved you guys a question, because now you're absolutely going to get it right, because it's absolutely going to be on this exam. This always happens. Every time you get burns, and that's the topic of discussion, those 3 questions happen. Period, point, paragraph. I hope I helped you with that. All right, next slide. All right, so integumentary burn treatment. This is also going to be something that is 100% going to be a deal on your exam. I don't know what exam it's going to be. It's going to be an exam, and it's going to include this question specifically. So airway management is always a hot topic. We need to know, after this type of burn, how much time do we have? So whoever did this slide, smart cookie, right? If intubation is needed, inhalation injury is treated with 100% humidified O2 and cough and deep breathing exercise is absolutely correct. You need to know that hot point as well. This Parkland formula, I'm going to be real with you. The fact that it's up here, the fact that we're talking about burn injury treatment, we're going to be talking about fluid management. It's going to be total crystalloid fluid the first 24 hours. Know this entire stinking formula. Whoever this genius was probably either knew, was related to, or is the same person as slide number 1 in their genius. This is equal amounts of genius. I don't know where you guys get this genius, but I'd like to think through osmosis I gave you a smidge, just a smidge, because you guys are starting to understand these patterns. I don't know if you realize this or not, but these first 2 slides have shown me that you guys know the pattern of the exams. You're starting to learn the Kool-Aid that I told you to drink 2 daggone semesters ago and said it was mystery flavor. You're starting to realize it's purple power. That's the real flavor, right? So good for you guys. You have to know the Parkland formula. Fluid therapy, obtain IV access. Yeah, for sure. Yep, give me 2 of them. Perfect. Yeah, everything on here is perfect. I wouldn't add a daggone thing. I will tell you the structure of these questions. It's going to tell you that there's a brand new patient with a total burn injury and we have to do fluid resuscitation. What does that look like based on the Parkland formula? That's a typical question. Also, what's a typical question is how do we effectively maintain an airway based off of smoke inhalation, right? That'll be one of them. And then I doubt we're going to, these are good points. But again, this is the big guy. These 2 are the big guys. Crystalloid solution we can find in the Parkland formula. Yes. Albumin is something that we use in combination as well. Yeah. This is just a solid slide. You have everything that you need. So, all right, next slide. All right. Integumentary burn treatment. Let's see. Told you guys, we had a kid that was going to scream. Come here, mama. Come here, mama. Uh-oh. It feels like it's nearly nap time. Nope, it's not. It's just that day. Come here. Come on. Let everybody hear your thunder. Oh, I know. I know. I don't like talking about burns either. I know, neither do they. All right, guys, so wound debridement. When we're talking about wound debridement, necrotic skin, necrotized skin, forms of necrosis there. Now I've atoned for all of the terrible grammatical errors I just made. That is always going to be a debridement procedure, so good for that. Dressing changes, proper PPE, yes, super important about that. Also maintaining other precautions, things we're going to probably anticipate, like neutropenic precautions for patients like this, depending on how terrible the burn is and depending on how immunosuppressed they are. Keep the room warm, yeah, you betcha. Because obviously they lose a lot of heat with all of these burns. Permanent skin coverage is the primary goal. Yeah, for sure. Know the difference between an allograft and autograft. Know it. It's going to usually be a question. What analgesics and sedatives? Obviously IV is best. Good. Tetanus immunization. Tell me why. Antimicrobial agents, yep, for sure. Heparin, yep, okay, good, that's good. Nutritional therapy is huge. There's always a question about protein management with these patients regarding nutritional therapy, so that's good. Preserve GI function, yep, make sure we're maintaining peristalsis. Increase intestinal blood flow, yeah, I like that as well for the same reasons. Promote optimal conditions for wound healing, very good. Okay, this is a solid slide. On this slide specifically, usually what I get is what type of analgesics are we giving for this patient? What's the PPE? What are we going to make sure we're not going to introduce to this patient? What pathogens? How are we going to protect ourselves from getting somebody else sick based off of us is how we need to look at PPE, so good. You need to know allograft versus autograft for sure. Know about your drug therapies. And nutritional therapy, they usually ask a question regarding, protein management. All right, next slide. All right, so integumentary burn treatment. Face can be swollen, often covered in ointments and gauze, but not wrapped to limit pressure. Very good. Ears, keep free from pressure. Good. Don't use pillows, right? Use rolled towel under the shoulders. Very good. Yep. Because that pressure from the pillow obviously is going to degrade that tissue. Hands and arms, extended rays on pillows to reduce edema. I love that for you guys. Splints can be applied. Perfect. Perineal care, keep as clean and dry as possible, prevent infection. Yes. Range of motion, maintain function, and prevents contractures. Yeah, I think all of those are good. In reference to anything additionally, that I've seen on an exam regarding this, I don't see a whole heck of a lot on the slide. Not saying that the slide isn't going to be absolutely imperative. I just haven't seen what angle we would take with this slide. Let me think about that, and I might come back to this slide or reference the slide later on, a couple of slides down, because just looking at this, as far as other care measures, the only thing that I think we would do if we were to do this is the pillows not rolled up under the shoulders so that we don't put that pressure down, as well as the pillows to reduce edema. Those would be probably the hot spots on this slide. But really beyond that, we don't ask a whole heck of a lot. We usually hit the big stuff like, what are we worried about with inhalation burn, right? Or what percentage of a burn is this? Or how do we manage that from fluid resuscitation based off of the scale, right? Those questions always pop up. These, if we're going to go at any angle, for some reason, how we're going to position the patient just seems to come to mind for obvious reasons. So that's what I got for this slide. Next slide. All right, so when we get into anemias, they always get for the same anemias, and they always ask the same questions for the same anemias based off of oncology and hematological management, yada, yada, yada. So here are the ones that we normally get. Signs and symptoms, right? So patient has complained of palpitations, is fatigued, has malaise, has a palish greenish color skin with severe tachycardia, that type of a deal. What is this most likely a presentation of, right? So anemia. Or another question is, what labs would you anticipate the doctor to request? So again, we would want to get a CBC because that's a complete blood count to include what our hemoglobin and hematocrit looks like and the things that we need to know, right? What do our red blood cells look like? What is that? What's going on with the internal structures of those cells? Interventions is always going to be a thing. There's always going to be a question about what type of dietary changes would you recommend for this type of patient? There's always what would you need to educate your patient on regarding medication management for anemia, who presents with blah da 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 type of stuff, and that would be medication management or education on constipation, right? Because or I suppose the diarrhea aspect of it, because it's either or with iron supplements, usually constipation though. Things of that nature. That's going to be kind of what anemia looks like. Also, I would add in there the different types of anemia. One big question is, the classic tall tale. Here's a patient who had bariatric surgery or is going to bariatric surgery. What do we need to educate the patient on? And of course, it's going to be the need to take B12 because you lose your intrinsic factor and you need to do that for life, right? And what type of anemia is that related to bariatric surgery, right? Versus what does plain old iron deficiency anemia look like versus what does pernicious anemia look like, which is a totally different presentation. So know your anemias, know what separates this type of anemia from that type of anemia, know the deficiency of the anemia and what the supplement is going to be and the care management of it is going to be and how we educate them. I know that covers a lot of ground and that seems super intimidating, but there's only a couple of anemias and they're so vastly different and specific. Come here. Come here. Do you really want to eat a pecan? Because you're going to hate a pecan. You weren't born in the South like your mother, so I assure you, you're not going to like the taste of a pecan. And if you do, it's because it's genetic, so you're welcome. Tell the ancestors I said hello. Go ahead. Go ahead, grab all of them, sure. Wolf them down. You're going to hate it. Sorry, I'm doing a different type of teaching moment. It's called being a mom for a toddler too early to be in the terrible twos, but hey, we're already here. There's that. She counts to 20. I guess, you take the good with the bad. All right. Oh, shocker. You don't like them. Okay, cool. What do I know, right? All right, so bouncing back to this. I like oxygen therapy added on. I like blood transfusions for sure. Drug therapy, erythropoietin. Why do we need erythropoietin? What does erythropoietin do? Where is erythropoietin located? What is it a hormone, and what organ has that hormone release and innervation? That type of a deal. All right. But not so much that piece. That's a pretty escalated question. But definitely iron deficiency versus pernicious anemia versus, all the other 4 anemias that there are to talk about right now that I'm not going to necessarily get into because I'm going to trust that you guys know those things already or we'll study them. But yeah, the big ones that show up are the B12 deficiency, iron supplements, also what juice you drink to increase the absorption of the iron. That's always a question. How often do we need to take the B12? What type of anemia is that? Is always a question. They really don't get into hemophilia as much with anemia, so I'm not worried about that. Yeah, that's it. This is a good slide. And now let's do... Oh, yeah, pica. Pica usually shows up. Backing up the train. Pica, desire to eat ice. That's usually iron deficiency anemia. All right, cool. You get the idea. Next slide. All right. Not very often in life do I have to admit that I am clearly wrong, but alas, it has happened. After 40 years of my life, I've finally been wrong. And you know who wronged me? My child, because she's 4 pecans in right now and there's no end in sight. So I was wrong. There, I said it. It is recorded. I admitted it one time. So there's that. So going back to this slide, there's a lot of information on the slide. The slide intimidates me. The slide's a lot. Whoever did this wants to make sure they have every piece and puzzle covered for this topic. And whoever did this was smart. So pay attention to this slide. It's clouded, it's crowded, and it's confounded, which technically rhymes. So, conversion of ammonia to urea, normally occurs in the liver. Absolutely accurate. Severe or serum ammonia levels, for sure, because it's noxious to the brain. Severe liver disease, yes, you're going to have severe ammonia levels, and you need to know potentially the medication that you take to get that ammonia out. And that medication would be lactulose. So normal for lactulose is you have 3 to 4 poops per day. The doctors in reality will tell you drink it 3 or 4 times a day until you start to have nearly liquid bowel movements regularly, and that's usually how that goes. It's orange. It tastes terrible. It tastes like castor oil. Yes, I've tasted it before because I wanted to know why my patients wouldn't drink it, and why they ended up coming in with ridiculously high ammonia levels to the point to where they're completely squirrely because of a beverage that they had to ingest. And now I know it makes very simple sense to me. Also, I know why people don't wear their CPAP masks, and they would rather not wear their CPAP and continue to have heart muscle degradation. I get that too. Why? Because I had someone put a CPAP mask on me for 5 minutes to see what it was about, because I talk mad trash about it, because I used to be the nurse that I always talk about that I can't stand, which is the nurse that walks in the door as a brand new nurse and is like, I know all the latest and the greatest and you are wrong. You ain't been to the bedside in so long, blah, 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 blah. First off, still at the bedside, so nah. Second off, don't be that guy, because they will eat you alive and I will watch it and eat some popcorn while it's happening. Because that person needs to jump up out of the gate, because you will never succeed in this profession. They will take you down. They don't like that person. Don't be that person. All right. Digressing. So, know the platelets, know the counts. Know when we start getting into crazy bad areas. So know when you need to be neutropenic. Double check me. I think it's 20,000. Know when I need to stop the heparin because my platelet counts are far too low, right? Know platelets. Know what medication goes with platelets versus what medication goes with. I didn't explain that right. Yes, ready, set, go. Know the medication that you need for warfarin therapy versus the medication you need for heparin therapy, which is pretty obvious. And then at that point, you also need to know the lab value. So which one is INR and why, which one is APTT and why. That one always shows up. I hope I explained that well. There's a question related to platelet degradation being too low and a stop in heparin. And I cannot for the life of me, that's why I'm dancing around talking kind of weird, because I'm trying to remember it to a T, but I can't. So it's something along the lines of, what is a platelet count that is either going to be indicative of someone on heparin therapy or someone needs to be shut off of heparin therapy. And I can't remember what the platelet count limit looked like even, but I remember seeing that and going, that's bizarre. I've never seen that question before. So I'm going to go back and try to find it. If not, just know those different ones. Know high, what that means. Know what polycythemia looks like. Know about splenomegaly. Perfect. Acute leukemia, DIC. Yes. Know, here goes. Here's another one. Know the number or the value that puts you at an increased risk of DIC. There is a value that puts you at an increased risk for DIC. Once it goes to blank and under, you're in a lot of trouble. Athena, stop. And then with thrombocytopenia purpura, you need to know its presentation. You need to know, again, what that lab value is, where we would include that into the diagnosis of thrombocytopenic purpura. Thrombocytopenic purpura. Try saying it 5 times fast. It's not very easy. And I have a kid jumping on me, literally. Know your bleeding precautions. Perfect. Use soft toothbrush. Love that. No straight razors. Love that. Avoid straining with bowel movements. Yes. And educating them on black tarry stools. Perfect. Yep, that's it. All right, next slide. Okay. So endocrine. Ugh. Endocrine is not my favorite. All right, monitor serum, calcium, and phosphorus after parathyroidectomy. Yes, after parathyroidectomy, for sure. All right, they are inverse electrolytes. Perfect. They may have hypocalcemia, yes, and hyperphosphatemia. First off, what does hypocalcemia look like? Because the way these questions are always posed is patient presents post-parathyroidectomy with blank and blank and blank in this scenario. What is the condition? And this will be obviously your correct answer. So I need for you to know hypocalcemia, hypophosphatemia related to post-parathyroidectomy, because I need for you to separate those. Lab values are one of those things that back when I was in school, we didn't necessarily have to know them to still get away with murder as a nurse. So lab values were just kind of meh. Now the expectation as I got into my doctoral practice turned into, by God, you better know your lab values. You better know why they are important. You better know what the limits are. I don't even care about those arrows they got on that epic charting. You need to know why, what to do to fix it. You need to anticipate, They get super big into pharm. They get super big into lab. And the reason is because our staffing is so terrible as nurses, the expectation for the nurses to do more and know more is greater because there's so many of us, right? And usually if you have 10 nurses back in the day, you were honestly over encumbered, and 4 of those nurses were super knowledgeable veteran nurses. Well, now, unfortunately, because all the super knowledgeable veteran nurses ran when COVID happened, and only a couple of us idiots stayed around to, cheat death every day. I say idiots, haha, because who would run into a fire besides the craziest people in the world, which are firefighters, nurses, military personnel, police, all of the other crazy people that aren't fearful of anything in this world. Those guys are the quote-unquote idiots, but those guys are the quote-unquote saviors of humanity, and you're going to be part of that. So you need to know this stuff in its entirety, because these questions are going to show up on your exams, whereas they didn't necessarily show up on mine in my bachelor program. So monitor the patient for signs of hypocalcemia. See, we're doing it again. Hypoparathyroidism. Watch for muscle twitching, tingling in the extremities, tetany, right? And laryngospasm. Why? What levels are so jacked up right now, which I already know, but I'm going to make you look it up. So hyperparathyroidism. Why are our muscles twitching? What am I deficient of? What do I have too much of? Right? That type of deal. Monitor airway is, yeah, for sure, super important. Post-operative swelling. There's always a question about that. Always a question about what do we need to worry about post-parathyroidectomy or post-thyroidectomy. And that's going to be our answer. Sorry, I'm watching a child trying to get into something they shouldn't be getting into, and it may cause some issues. Yes, I love this box. Parathyroidectomy removes parathyroid glands. Perfect. It's used for hyperthyroidism. Perfect. Which causes, yes, good. I love that. Yes, know your hyperparathyroidism and know your hypercalcemia. See, you've already done half of the work right there. Perfect. Yes, that's the questions you're going to get on this. It usually doesn't deviate from that. They may ask a question about your T2, T3, T4 levels, and what other labs you're going to need to get for a patient who has suspicion for hyper or hypothyroidism. That's usually another good question. And I see that your next slide is also endocrine, so let me see what that looks like. And let's flip on over. All right, so endocrine hypoglycemia. Okay, so we've moved on from our last slide. Just remember all those points I talked about for last slide. Also, what is your sign and symptom for hyper versus hypothyroidism? What examination lab values are you going to expect your doctor to get in regards to that? And what is going to be the threshold to let you know that it's either hypo or hyper? Okay, that's all I got for that. For hypoglycemia, I always get the 15-15 rule. I always get the question about if you were exercising, what would be the nutritional supplement regarding a diabetic patient? There's always that, like how many more carbs do I add on to whatever. I always get the what is our emergency management intravenously for a severe hypoglycemia, which is the D10 injection that we give. I always get education on diabetes emergency management questions, like what do we need to tell our patient to use, but that's in there, so I like that. Yeah, I think that's pretty much all I got for this slide, so we'll go to the next one. All right, endocrine, diabetic ketoacidosis. It is life-threatening. Severe hyperglycemia, accurate. Excessive thirst, yeah. Frequent urination, accurate. High blood sugar levels, yeah. They're usually the ones that just say high, and we have to do an actual glucose test that's separate from just a regular stick to find out what the actual sugar level is. Fruity smelling breath, acetone. Remember, these guys are a respiratory acidosis. We know that because the fruity breath smells of acetone, and for about 15 other reasons I can talk about right now. But there's really no purpose in that because I don't think we're going to bring up that type of a question, but just so you know. Oh, Kussmaul respirations. That's always a question associated with DKA. And then it's going to ask, or potentially it's going to describe the Kussmaul respiration, so understand that you know what that means. Hypotension, orthostatic hypotension, diabetic or metabolic acidosis, like I said earlier, so that's cool. Again, a lot of ketones have a positive charge, which gives you that acidic property, blah, da, 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 which is why we're in metabolic acidosis. Risk for hypovolemic shock, super important. Medication management obviously is going to be an insulin drip that's going to need hourly glucose checks. That's always a question regarding diabetic ketoacidosis and management. Also, is the patient confused? Because I didn't see confusion. Oh, there it is. Confused or altered mental status. Perfect. Athena, Nicola, Isadora, Ophelia, Newman. If you do not stop knocking things over because you want me to play with you, and you know that I'm spending 30 seconds doing something other than playing with you, then I am going to act really angry, but not be at all, but change my voice to where it sounds like I'm lecturing you until you understand you need to stop. Do you understand me? Feel the fear. Feel the anger in my voice. God, I'm such a pushover. It's a wonder any of my kids thrive. You see this? You hear this? Child walking over me and I'm just letting it happen. It's gross. It's because she's cool, man. It's because she's cool. All right. Back to this. High chance in altered mental status of patient. Yeah, if patient develops cerebral edema, how do we handle the cerebral edema? That's another question that usually comes up as an alternate question. Cardiac monitoring. All right, cool. What cardiac changes will we expect? Perfect. Inverse with hypo and peak T waves. Yes, absolutely. When you are hypokalemic, you will have a presentation and adaptation of a U wave. How I remember that is P for potassium, PU, and I'm waving my hand like I smell a skunk, and I'm waving it down to get that stinky air out of my face. So PU is for hypokalemia, low potassium. Please stop putting things in my face. I don't want a sock in my face. Thank you, ma'am. Thank you. Sorry. It's really hard to record these things when you have this going on. And you guys know I don't edit. So, hooray. All right, next slide. Okay, so, oh, good. There's another one. All right, so acute kidney injury, yep. Cardiac arrhythmias and disturbances due to electrolyte imbalances. Would know which ones. Okay, good. I like that about the hypokalemia. I like all of that. We talked about an insulin drip earlier. Yep, fluids are likely LR. Perfect. Also know the anion gap. So the anion gap, it lets us know when to shut off the insulin drip. So what number is the anion, A-N-I-O-N? Have you guys ever heard of that before? Athena, Nicola, Isadora, Ophelia, Newman. I might have just screamed her name. I might have just blessed her out. This is what happens, right? So yes, that was purposeful. So yeah, know your anion gap. You need to know that. Know what it is. Know what the threshold is, and know what the limitation is for us to require an insulin drip and to stop an insulin drip based off of not their blood sugar levels, but their anion gap, because that's actually the predicting factor that lets us shut it off or requires us to have one on. Next slide. All right, so hypomagnesemia, hypermagnesemia, yes, those are both on here. You need to know the causes, the signs and symptoms, diagnosis, what creates the diagnosis, what's the threshold, so you got that under 1.3, good. What are the signs and symptoms? Anorexia, depression, disorientation. Okay, cool. What about over? Yep, those are good. Add comatose if you're over levels of 15 with your MAG, which I've never seen levels that high. Yeah, that's good. Adrenal insufficiency or Addison's disease. Hypothyroidism. Perfect. And then obviously what's the management? Management is to put it back into the range of 2. Is kind of where we want things. That's what's usual for hospital protocol. So have it to 1.8 to 2. So that way you're kind of floating in between the two. Yeah, I like all of this. I like all of this a lot. So know your causes for hyper, know the signs and symptoms. I feel like there's more signs and symptoms for hypomagnesemia. I don't know why I'm thinking there are. I'm thinking, don't quote me on this, but I'm thinking seizure for some reason. Hang on. Hypo. I might be lying. Magnesemia. Life-threatening. Sorry, guys. It's worth the Google. Arrhythmia, coronary artery spasm, sudden death for hypomagnesemia. And seizures? Let's see. Hypomagnesemia is often asymptomatic until the levels are less than 1.2. Da 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 da. A increase in the extracellular magnesium causes a great influx of calcium, resulting in an even greater release of neurotransmitters. Right. Haha! Increased glutamate mediated depolarization of the brain can cause seizures. Boom! Wah, 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 ba, meow, ba, meow. I did it. Yay. Okay, so I knew I was missing something. I believe signs and symptoms on there for hypomagnesemia also needs to include seizure. All right. So I just gave it a quick Google, double check me on it, but I don't know what other Google you would do, but that's an accurate statement. And also important because you need to know the life-threatening for magnesium for hypo and hyper, because this also relates to people with pregnancy. That's also a question related to magnesium, and it's also related to seizure, if I'm not mistaken. And I believe it was a case of hypomagnesemia. So double check all of those points of contingency, because I usually don't do postpartum or interim partum. So make sure I'm not lying to you, but I don't think that I am. I also have a fussy baby because she's ready for her nap finally, thank the Lord. So I'm going to put her down and we will go to the next slide, and yeah, we'll keep going. All right, fluid volume and electrolytes, calcium. I love this. Calcium doesn't get talked about often. Calcium will come up in your NCLEX and in your exit HESI quite a bit because we just don't talk about it that much. So you might see 2 or 3 questions regarding hypo and hypercalcemia. So these are really advanced questions that I don't want you to miss an opportunity on answering appropriately. And yes, vitamin D causes hypercalcemia. Very good. And that's vitamin D intoxication, because vitamin D is fat soluble and not water soluble. So A, D, E, and K are all fat solubles, which means you can get toxicity. Hyperparathyroidism, yep. Know your signs and symptoms. Know your signs and symptoms of hypo and hyper. No positive Trousseau sign for hypocalcemia. That's going to be a thing. Convulsions, yep. Numbness and tingling, yep. Diarrhea for sure. Tetany, yep. All right, cool. This is a solid slide. Know your levels, know your values, know hypocalcemia and positive Trousseau sign. Know convulsions for hypocalcemia, know what causes it. Same for hypercalcemia. All right, next slide. Okay, fluid volume, electrolytes, circulatory overload, fluid overload. Okay, cool. Heart failure, kidney or liver failure, right. High salt diet, perfect. So first off, what is the fluid volume and electrolyte diet education, which is going to be a low sodium cardiac 2-gram diet, good. Kidney or liver failure, right. What are we going to do about that? Well, we're going to have to make sure we don't end up with pulmonary hypertension because of this problem. We are going to listen to lungs for the wet cough and crackle sound that's indicative of we're going to need medication. Also, what's the medication that we're going to use for exacerbation of heart failure or any type of fluid in the lungs? And how fast do we need to push it? And what happens if we push it too fast and get ototoxicity? And what will that do to my creatinine? It'll raise it sky high with every dose you give, right? Because we have to remove fluid, which means we're going to have increased sodium, yada, yada, yada. So know that type of stuff. Distended neck veins, we know that because it's overloaded to the right side. Elevate the head of the bed. Why? Why are we doing that? What does that have to do with intracranial pressure? What does that have to do with taking care of volume overload related to fluid in the lungs, et cetera, et cetera? Keep the client warm. Yep. Notify healthcare provider. Perfect. What medications are we going to anticipate with these types of patients? What diet and regimen are we going to anticipate educating them on? I think that's as far as we go. Sometimes we go as far as to say, what is it called? For the love of Pete. There's too much going on right now. Stop talking, Athena. Hang on. What is the osmolarity and osmolality? Perfect. Sometimes it's going to ask you about the osmolarity, the urine osmolarity or urine osmolality. Just as a side note, make sure that you understand those levels and what they do and what they mean. because they're going to tell you that a person with chronic Lasix injections related to compensatory heart failure has now had 24-hour urine done. What is the expected osmolarity or osmolality based on this patient and their recurrent use of Lasix? Sometimes that's a weird question that pops up. So know those levels and know that our level of salt to fluid is going to be disturbed because the fluid level is going to be removed and all that's going to remain is the junk that remains, right? So know your urine osmolarity and osmolality. Know about 24-hour urine as well. I like all of these things. I got nothing else to add besides all of the aforementioned. Next slide. All right, hypovolemic shock. Yep. Know what causes hypovolemic shock. Know what situation would predicate that. So, I don't know, a shark bite in Columbus, Ohio. Yeah, for sure. That's going to cause hypovolemic shock. And also is going to cause an uproar because everyone's going to know where the heck you found ocean water and a great white to lob off your arm in one fell swoop in the Ohio River. I'm just saying. There's that. Let's see. Fluid replacement. What is the level of fluid replacement when we're dealing with hypovolemic shock, right? Know that. Monitor for fluid volume overload with fluid admin. Yes, that is accurate as well. Flat neck veins. Yep, because these are signs and symptoms of not having enough fluid in our body. Increased heart rate, low BP. Of course. Low weight. Yep. Decreased skin turgor. Yep. So how do we manage all of these things? What else do I get with this? It's usually just fluid resuscitation and management and tourniquet placement if it's got to do with the bleed. Yeah, that's all I got for this slide. Good job. Okay, so renal and urinary chronic renal failure. We need to know about hemodialysis. What can go wrong with hemodialysis? Know the difference between hemodialysis, traditional, and peritoneal. Know that we need to give them midodrine if their blood pressure is too low prior to them getting dialysis. Know the manifestations. Perfect. Observe for complications. Anemia. Why? Because there's no erythropoietin, because the erythropoietin stores have depleted out along with the kidney failure. Severe resistant hypertension. Yep. That's a big problem. Infection and metabolic acidosis. Yes, absolutely. Yep. I love what we monitor for. Maintain strict eyes and nose is always going to be a thing. There's always a question about what does a peritoneal or what does a traditional dialysis patient not need to have included in their diet. There's always that question. There's always what medications do you not give your patient, and those are those are medications that are based on increasing the potassium. So there are certain meds you won't give specific to a patient with dialysis because of that. Yeah, so I like all of those things, and that's usually what you get. Also knowing what GFR levels go with what type of renal failure, but if we're just talking about chronic renal failure, it can kind of go variable, so I don't think they're going to go in that route. But I might want to know what level of renal failure goes with what GFR level. But beyond that, this looks good, so next slide. When we talk about peritoneal dialysis and we talk about these examinations, usually you always check for discomfort of pain. Usually you check for signs and symptoms of infection and what does that look like. A bruit for sure, feel for thrill, perfect. Monitor for fluid imbalance. It's pretty much that's all you get when you're talking about peritoneal dialysis is what can go wrong, how do we fix it, what's the biggest scariest thing to watch out for, how do we educate them, and yeah, you got it all there. So know this slide, know the couple of extra things I told you to look up, and then move on. All right, kidney stones. First off, what's the formal name for it? Know that. Yep, different types. I like that for you. What is the diet to keep away from having these kidney stones? Is that on there? I like the Flomax. Good. Encourage oral fluids. Yep. Strain all urine. Yep. Perfect. Education. Dietary, perfect. Depending on the type of stone, good. Yeah, this is everything that's ever going to come up about a kidney stone. Also, signs and symptoms of a kidney stone, which are pretty obvious at this point. But yeah, I like this slide. Let's go to the next one. All right, glomerulonephritis. Nephrotoxic drugs, which ones? Immune disorders, which ones? Yep. Hypertension, increased ECF volume, yep. Huge abdominal or flank pain. This is called the chandelier test. We will tap over the palm of our hand over the area of the kidney or the flank, and they will jump to the chandelier test. Anti-nuclear antibody test, very good. That's important. Dipstick urinalysis, yes. For erythrocytes, yep. BUN and creatinine. What is our creatinine going to look like with glomerulonephritis? What is the medication management for glomerulonephritis? What is the fluid management for glomerulonephritis? Administer diuretics. Good. Decrease edema. Love that. Restrict protein. Okay, cool. Why? Antibiotics, very good. Take entire prescription. Yes, I love all of this. So yeah, it looks like you got this one covered other than the couple of dumb things that I said. Make sure that you understand fluid management for this patient. Make sure that you understand the restricted protein and the why. Yep, manifestations are perfect. Yep. Okay, that's it. That's all I have for this slide. Next slide. Okay, this question is all over the place. Dealing with the elderly, dealing with the levels, dealing with the medication management, dealing with how we do the actual test. Is it clean catch? Is it just a sensitivity and culture? Do we sensitivity and culture? So you're going to have 5,000 questions that could be part of the UTI panel. All of these look really good. I would also add in, delirium. Is another one that we normally get in the elderly. I love how Escherichia coli is the most common infectious agent because that's also a question I've seen pop up. Yes, urine culture and sensitivity confirms suspected UTI, identifies the organism. The sensitivity is going to let you know what it's sensitive to, so we know what antibiotic therapy to use. Yeah, I like this. I like everything about it. I got nothing to add other than, I saw one question one time about cranberry juice. And the question was posed as the nurse is educating the patient about persistent UTIs and tells them that cranberry juice is good in, and then it wants you to know the function of the cranberry juice and its properties that aid in the UTI. What is it about the cranberry juice that actually helps with the UTI? I'm going to make you look it up because I was actually pretty surprised. Of all the things in the world, that was the answer. And I thought, well, that makes a lot of sense now, but I would have never have come to that conclusion in a million years. So, fun factoid, look it up. Are you going to get that rando question? You might, because I remember that rando question was in the last 6 months that I've seen it. For sure. So look it up because it's good knowledge to have and it's good education to give your patients. They might actually be apt to actually drink it and use it because a lot of people won't do it because it tastes terrible. So if they knew that little factoid of actually how it works, many of them might go, oh, okay, well, now that you've given me the physical answer, I might actually believe what you have to say and I might actually subscribe to it. So give it a go. Next slide. All right, for neuro, EMG, yep. Diagnostic procedure, good. Yep. Yes. Sorry, I'm reading. Yeah, I like this, good. Avoid smoking for at least 3 hours before. Why? Know the why, and know what that would do to disrupt the test if you did. Wear comfortable clothing that's not obstructive. I think we know why for that. Yep. It is a very low-risk exam. Know what a positive finding indicates. And also know what it's specific for. And I think that's as far as we're going to go with EMGs, because I haven't seen a ton of questions related to EMGs. It's usually identifying based off of the patient's client or the patient's history of persistent pain related to, muscle or nerve issues, tingling, numbness, which imaging study would you indicate the doctor to provide the patient with? And then EMG would be the answer, obviously. Athena, you're on my last nerve, child. Here. I'm getting sick of it. I'm getting sick of it. The world is not just about you, child. There are others, I swear. Nearly 8 billion of them. Okay. Sorry about that. So that's all I'm going to get for this one, I'm pretty sure. So we can go to the next slide. All right, tonic-clonic seizures. There's 1,000 questions about tonic-clonic seizures. It's absolutely going to come up. First off, everything on the slide, completely imperative, no, period, point, paragraph. What are you going to get? You're going to get anything from what does a tonic-clonic seizure look like to what does post-ictal state look like to how to record post-ictal state and seizure. By the way, if you record a seizure, you record a seizure from the beginning until the entirety, including the time in between the post-ictal state. That is the clinical definition of how we record that. You're getting everything from start to finish, including post-ictal and how long. What medication do we give to stop it if it's at bedside? What medication do we give to manage it? So it can be anything from Keppra to Vimpat. What levels do we need to look at? Dilantin, right? Like you need to figure all that out. What else? What's the other name for Dilantin? What about phenytoin, right? Make sure you understand that concept as well. Seizure can also include the discussion of education on the seizure, specific to don't put in a bi-block if they've already started. It can go into, doesn't get into the receptors of the brain. I think I've hit all the big hot spots. What do we need to maintain? Patent airway. Seizure precautions and seizure pads fall into this line. What side we turn them to. How we never stick our fingers in their mouth. Yeah, that's seizure, right? Including in with all of these things here. What does a tonic-clonic look like? What are the triggers of a tonic-clonic? Yeah, those things. Those show up. All the other stuff, usually good. Vagal nerve stimulator, this is after we've exhausted all medication management, and now we're adding on to the medication management. And then sometimes we actually do a hemicranie to remove that area of the brain that was causing a fire of the seizure. Or we have neurostimulators like this one right here that basically does the same. So yeah, that's everything I got for this slide. There's a lot with seizures. Like what's withdrawal period for seizures for specific, disease processes like alcohol withdrawal, right? 3 days. What scale do we use? SIWA, right? What do we do for heroin? CALS. What's the level for SIWA? Anything 12 or above, we're going to give meds for. That type of a deal also falls under tonic-clonic seizure. So I hope I helped you with this. There's a lot of ground to cover, and I don't know what you guys are learning. So if any of that sounded like you've heard it before, put it down. Yeah, write it down, because that's the thing probably. All right, next slide. All right. So people call this Guillain-Barré. People call it Guillain-Barré. People call it Julianne-Barr. The answer is, it's however you pronounce it, because the bottom line is between this and myasthenia, you need to know the difference. This is a tall tale, classic thing that will always show up on your NCLEX, will always show up on your exit HESI, will always show up on your standardized tests. Because one of them is super serious and the other one's pretty darn serious, but not to the point where it's going to kill you if you don't do something. And there's no in between. So, I prefer to call it Guillain-Barré. Guillain-Barré syndrome is an autoimmune reaction. that follows a primary disorder, much like other autoimmune reactions. It attacks the Schwann cells in the myelin sheath. I love whoever did this slide because I almost never see the description of the pathophysiology behind it. But that's what happens. And the nerve transmission becomes abnormal, benign, shaken, shook, whatever you want to call it, right? Risk factors are perfect. I love all those. All those are accurate. Expected findings, mild to severe ascending muscle weakness, as in it starts in the feet and it goes to the head. Okay? So this is important because Guillain-Barré syndrome is not as scary as myasthenia. Can it go all the way up? Yep, it can. Can it cause problem swallowing? Yep, it can. Is it something that can be reversed with IVIG? It can. And besides having a fall risk and increased anxiety and muscle atrophy and it being a terrible thing, and us confirming it with an LP and getting CSF, it is not as scary as myasthenia. So, it's going to tell you basically a patient is presenting with recent recurrent weakness starting at the feet and working its way up into the abdomen. Once it hits the diaphragm, we start having problems, right? Because of breathing, because of risk of aspiration, because of weakening of those muscles, right? So what is this condition called? That is usually what you get. Or you get a question about the immunosuppression and the therapy, I just told you. Or you talk about what would be an expected examination to confirm this suspected diagnosis, and that would be an LP, right? That's usually what you get for Guillain-Barré. Now, let's go to the next slide and see if we're going to go into myasthenia. Because myasthenia is the one that always shows up as the emergent. They got to have emergent intubation because they are from top to bottom. So they descend. So they start at the head and the throat goes next. So the second that they start having facial weakness, they know that the throat's coming. They go to the emergency room. We do an elective intubation right then and there. We don't even think about it. That's myasthenia. I've only had about 9 of those patients in my entire career. The only time, well, not the only, but the only time I've severely been concerned about a patient in a condition that I felt uncomfortable about within the neuro spectrum is myasthenia. Really, it really is. Like, I've had some rare disorders. I've had trigeminal neuralgia a couple of times, confirmed, like real trigeminal neuralgia, not people who say they got it and don't understand what it really means. Like, everything's cool, and in mid-sentence they go from that to blood-curdling scream because they hit that type of a deal. That doesn't bother me as much as myasthenia. Please understand, when you see a question about myasthenia, it's going to talk about intubation. All right, and IVIG is going to be the deal for that too, and it takes a long time to fix it, and elective intubation is usually the answer regarding myasthenia, and it is an absolute medical emergency. Okay, and I think that's all I got for that. So yeah, let's move on to the next slide. I like this whole slide. Diagnostic procedure, this is going to be our way to go for this. I like all of our nursing care and things of that nature, and then of course everything that I've talked about prior to regarding myasthenia and Guillain-Barré. Whatever that looks like for you guys, whatever there was a gap in, just make sure you have those gaps filled in, because again, I'm not really sure what angle we're taking this from, but I know the angles that we usually take it in. So I hope that was helpful. So next slide. All right, I love this slide. I love it because we can clearly see what all of these mean, and we can clearly see what severe, moderate, and mid is. Glasgow usually confuses a lot of people because it's backwards, basically the scoring is. We're used to the higher score meaning the badder thing. In this case, it's not. So you get a point if you're able, and if you can't, you don't. And that's kind of how this works. So here are all of the fantastic, yeah, this is a great slide. So everything on the slide you need to know, and what it's going to ask you regarding the Glasgow Coma Scale, or a couple of things. It's going to tell you that the patient is obtunded and da-da-da-da-da-da. What is the scale? Is it moderate, mild, or severe? So you can learn this two different ways. You can just learn it by knowing the signs and symptoms and knowing which piece they fall into, or you could actually learn the point system and know that if your patient does this but doesn't do this, then they're definitely going to score at least this. So you can kind of guesstimate and put them into the blocks based off of their score if you know the scoring system. However you want to study this, study it, but you got to know it, bottom line, because this is going to be good for at least 2 questions on your NCLEX, at least 1 question on your exit Hesse and standardized testing is the Glasgow. Or it's going to ask you what type of scale you need based off of the patient's findings and symptoms. So either you're going to have to calculate it and say whether it's moderate, mild, or severe, or you're going to have to recognize that that is the type of scaling you need for this type of patient. And I really don't see any other variance in between. So yeah, next slide. All right, neurological assessment. Yeah. Okay, good. Yeah, this is a good slide. I don't really know. Maybe we're going to ask, how do we identify the neurological status of a patient? Maybe we're going to say if a patient is not alert and oriented to person, place, and time, they're going to be at increased risk for falls. Maybe that's where we're going with the angle for this type of question. I've never seen a question about don't force a patient to attempt tasks beyond their limitations, but I like that. I like that a lot because you shouldn't. What reflexes are we checking in a neuro assessment? And what are we looking for? What scale do we use to determine a neuro assessment if there is a suspected stroke? That's NIHSS. What else would I have with this? There's a ton. Okay, so here's one. In the eye examination portion of neurological assessment, which cranial nerve do you use for the 6 fields of gaze? I mean, like, we could go anywhere with this slide. So I'm not really sure what you guys were talking about or what the lecture was over when you talked about a neurological assessment. So I'm not sure if it includes the physical assessment of the eyes and what that means, or if we're just going like brain, spine, and being done, which would also include an eye exam. I'm not really sure what to do with this slide. But I will tell you that all of these points of contingency on this slide look really, really good. I just don't know what it was that we were studying because obviously I don't have the blueprint. But if I were to go in any directions looking at these notes, I would go into those directions. Balance and coordination. What are we testing? How do we test it? And what cranial nerve do we test it with? Like by exit Hesse, these are the things I would expect to hear versus this slide is more health assessment, like basic health assessment related. So on an exit Hesse, part of me goes, well, maybe they would do it that way because 80% of your exam is health assessment, but at this being the exit point, but not quite the NCLEX, we would challenge our students. So clearly at that point, if we were challenging our students, we would ask them, with a patient with a balance and coordination issues, what cranial nerve is that going to innervate? And we're going to be testing the vestibular cochlear nerve, cranial nerve 8. That's what that's for. So I don't know which way to take this. So take that information and dive into it in whatever angle you feel is necessary. Because I really don't know from an exit Hesse standpoint how would we want to appropriate what they're going to need to know for the NCLEX and ask the basic health assessment question that includes everything on the slide. Or would we want to take it and challenge them one last time prior to, so that the expectation is they study harder because the demand and the expected demand is going to be greater. I just don't know which way we're going to take that. So that's my thoughts on that. And that's the organizational psychology behind how we're going to write that test. So, sorry. Hope that helps. Next slide. All right, eyes. Yeah, for sure. Okay, good. So this fixes my problem because I was really stressing how we were going to do this. So yeah, neurological assessment on the eyes. Know the size, shape, movement. Yeah. Know the dysregulation, know the basic ones, know, yes, assess eye movement, 6-point of gaze, know how do we check for diplopia, what is diplopia, what is strabismus, how do we check for that, what are the official tests, how do we check vision acuity, what chart do we use, what do we use for an eye exam chart for modification for children, right? It's that weird e-chart or whatever you call it. So know those bits and bobs if that's something that were on your slides. Yes, Cushing's tirade is usually also indicated as well. It tells you about increased ICP. Also, pupils that are irregular in size. Say you have one that is 2 and one that's a 5. What does that indicate? That indicates a hemorrhagic stroke with a potential midline shift, like things like that. You need to know. Or if they talk about, spots in the eye, like brown spots, those are a benign process, and they're usually predictive of a person who has a darker ethnicity, right? So either indigenous, because I got brown spots in mine, my kids do, African American, things of that nature, Cuban for sure. I can go on for a while, but you get my drift. So that's something that you would normally see in people who are non-white, although there are some degrees of variance depending on what that looks like from a genetic ancestral perspective, because we're all a little bit of something, right? So that comes up a little bit. Diabetic neuropathy, or diabetic retinopathy, I apologize, comes up sometimes with neurological assessment. Know the pronator drift, yep, for sure. Yeah, this looks good. I don't think I'd add a whole heck of a lot other than what I've talked about, so I would keep studying kind of in that direction. Next slide. I'm not going to lie, there's a point of pride where I see post-craniotomy interventions and I'm like, wait, this is a slide? This is a slide of something you guys are studying? In the capstone, like for real, that's the thing. That is beautiful, because you guys will never get this experience again unless you work in neuro ICU, or if you work on a neuro unit. If you don't, you're probably never going to get it again or never see it, and I would love for you to be introduced to it because it is awesome. So yes, phase 1, phase 2, phase 3, know them, know what we're looking for, know what we're afraid for, and then move on, because you're never going to see this again. I've never seen a question about a post-craniotomy on an NCLEX. Or an exit HESI. I'm saying that because, no, I really haven't. Post-craniotomies are just like that very, very fine-tuned field. Kind of like talking about open hearts. It's its own little beast. It's its own little small infrastructure. So it's not something that is going to be a wide range at a med-surg unit. So it wouldn't be something we would include onto an NCLEX often or at all. So I'm excited to see what this is about. I want to know what this question was about. I want you guys to, if you can, tell me kind of what angle the question went in, because I am just super excited that we're even talking about post-cranies. This is fantastic. So yeah, know your phases, and know what we're worried about, most importantly, and the most severe risk within the first 72 hours, and then move on. Next slide. More post-craniotomy interventions? No. Wow, this is amazing. Yeah, we're going to look for signs and symptoms of complications and mentation. Yeah, I get that. We just had a piece of our brain taken out. There's just that. Yeah, assess the site. We don't want it infected. Sure. Yeah, all of those. Look at those as well and put those into consideration. I really don't know what angle we're going to go at with this. This is so bizarre for me. So I'm really excited to see what happens. If that's even a thing, I'm super surprised. Yeah, next slide. All right, myocardial infarct. Oh boy, this could go anywhere. This can go anywhere from what ejection fraction is indicative of complete heart block to tell me right heart failure versus left heart failure. So if I've got crackling in the lungs, is that left or right? It's left. If I have JVD, is it left or right? It's right. It could talk about cardiomegaly. It could talk about testing troponins and those levels. It could talk about creatinine kinase. It could talk about echocardiogram findings. It could ask you about MONA and what we need to add on when we're doing our regimen for MONA. It could talk about angina, stable or unstable. It could talk about the medications that you're getting and how you're having an asthma attack, post-myocardial infarct, and you don't know why because your asthma is normally managed, but you're on labetalol as a new medication. Like, it could go anywhere. So I don't know where to go. I don't know what to tell you. It could go into triglyceride levels and what the expected triglyceride levels are, and you got to find it. Right? It could go into what's your LDL that's in a poor way or would increase your risk for an MI. It could go into what are the symptoms of an infarct and what is our immediate management of that infarct. What medications are we going to stick them on? Once it's confirmed, what are we going to put them on? A nitro drip and heparin, more than likely. Yeah, I could literally go for days on this topic because we just went from a very, very, very narrow scope and spectrum to as wide as the Adriatic Sea. So do with that slide what you will, because I don't know what direction to go into with that because there's 9,000 to go into. But you guys get the idea of what they're looking for. Hopefully that helps. All right, STEMI versus InSTEMI is always going to be the same questions. It's going to be what is the difference between a STEMI versus an InSTEMI, and that's the ST elevation, which is going to be a complete MI versus an InSTEMI. What is the troponin level for a confirmed versus an InSTEMI? What are the signs and symptoms of both? What's the management for both? But yeah, that's usually the questions you get for that. Next slide. All right, so when we talk about VTAC, we want to know how many beats is defining a true VTAC. What do we do for VTAC? Is VTAC a big deal? It's going to be a big deal for all nurses in your first year. After that, it's not going to be a big deal because VTAC, sometimes people just naturally VTAC, 4 or 5 beats because they're just in cardiac failure. So it just is what it is. And other times it's going to be new and we're all going to go running. But as a brand new nurse, you're always going to freak out about VTAC. You're always going to freak out about a PVC even. And then you'll see, 40 and 50 beat runs of PVCs and roll your eyes and go, whatever. This is just what they do. But until you get there, you're going to be worried. So what do we give for it? What are our basic medications that we give for it? How do we fix it? Do we pace it? Do we synchronize it? Do we shock it? Those type of deals. By the way, we don't. So yeah, that's usually the direction those go into. Or they will give you the actual strip and you're going to have to just be able to recognize it. So next slide. All right, pericarditis. It always goes into the same deals, every question. What type of pericarditis? Because that's going to matter how they got it. What are the bigger deals related to pericarditis? What are their symptoms? How can you get it? They usually ask the question about having a history of rheumatic fever, along with the signs and symptoms that they're having. And then cardiac tamponade is a big deal related to pericarditis. And the best way that you listen to cardiac tamponade is you have them sit straight up and then lean forward. That is going to increase the sound of the cardiac tamponade. It's also going to hurt. But that's kind of how it goes. Again, progressive chest pain that worsens with movement. So the way we usually get these is patient with a history of rheumatic fever comes into the hospital with progressive chest pain that worsens with movement, referred pain in the trapezius muscle, and then we hear a pericardial friction rub. What is the likely condition? That's usually what we get. But all of these points are important because Dressler syndrome is also a piece of that, although I've never seen a question about it. I always see it related to rheumatic or rheumatologic diseases or rheumatic fever. That's how I always see it. Or, nope, I've never seen it with lupus. I've always seen it with rheumatic fever or rheumatologic diseases. But it just says rheumatologic diseases. It doesn't go into the type of. But for sure, rheumatic fever. Okay, that's all I got for this one. Next slide. I mean, to whoever did this slide, my hands up, my hat tipped, because here's the deal. Congestive heart failure is like me saying, go get me a blue shirt. How many shades of blue are there? How many angles of congestive heart failure do we go into? How many angles do we usually see in all of these tests? 15,000 is the answer. 15,001 might be, I don't know. But I can tell you they always go into the same directions. What's the medication management for exacerbation of congestive heart failure? What do you need to worry about when giving that medication specific to labs? So potassium, your creatinine going up. What is, pushing that medication too fast going to cause in a patient with congestive heart failure? Ototoxicity. What does left-sided sound like versus right-sided? Patient presents with a JVD. This is indicative of what? Right-sided heart failure. Symptoms of all of these. Dietary requirements we're going to give them. Where there's crackles in the lungs, what side is that versus where is this at, right? Peripheral edema and ascites, things of that nature, right-sided versus left-sided. You guys know how to do this. I feel like we just beat congestive heart failure to death, and we do it because everyone's got it. So if you see it a lot, you're going to get a lot of questions about it. It's just the way it is. So those are the angles I would go with those, as well as all these other points that you have, because I do like a lot of these signs and symptoms that we don't talk about very often. Like right upper quadrant pain on right side of heart failure. That's not something we usually get into too much, right? So good on you for that one. I like that. Next slide. Yeah, sure. And as we continue, we talk about cardiac catheterizations when we need to do those. Good. We talk about medications we do and don't take. What we have to watch out for if we have congestive heart failure and asthma, right? What do we got to watch out for as far as beta blockers, right? That's always a thing. I don't get a lot of questions about heart transplant or valve repairs or placement unless they're post-surgical. So ablation comes through every now and again, but it's only related to the procedure. Like what is the procedure? What are we educating them on the procedure type of a deal? What ACE inhibitors do we give? Why would we give DIG? What do we have to watch out for? What does toxicity mean? What does my apical pulse need to be? Those kind of questions. What are the potassium sparing versus the potassium saving? What other medications would I not take if I were taking potassium sparing diuretics, or what other foods would I avoid? The angles that you go into. All right, next slide. The dreaded maternity. I like all of this. Infant heart failure output and assessment. Yeah, I like all of those. And it's always the same question about this. It's always going to be about, is this fetal heart rate appropriate? All right? It's always going to be that. So know your normal fetal heart rates, know the signs and symptoms, and know that it's going to be observable and there's going to be no change because it's a normal finding, or it's abnormal and we got to do something immediately because we're talking about a baby. I mean, that's basically all that there is to it regarding this piece at least. Next slide. And I like this one as well because this goes into every scenario I've ever seen on an infant heart failure question. Literally every question that I ever see is related to these. Foramen ovale is another one I see often related to heart failure and infants. So, and I don't see that on this slide, so I would probably add that onto my list just because, if that was on one of your slides that you got from Elsevier, whoever it was that you guys use. Next slide. All right. You need to know all of these different types of signs and what it looks like. Just YouTube it if I were you, because they're going to ask about these signs. Babinski always comes up. I don't know why Babinski always comes up, but Babinski is always there. Brzezinski's is always there as well. Yeah, everything else looks good on here. Just know what that presentation looks like and know what abnormal findings look like, and you should be good to go. All right, so gastrointestinal or ileostomy. So questions that are common for this is, what does the stoma look like? What's it supposed to look like? What's an emergency look like? What does that cause? So you'll need to know purple bad, red good, necrosis bad, beefy good, that type of a deal. It'll also ask for education, if it's an upper ileostomy versus a lower, how we educate our patients about the texture of the stool. Obviously, if it's lower, it's going to be more liquid. If it's higher, it's going to be more solid because it hasn't had all that time for those villi and microvilli to pull at those nutrients and just leave the byproduct of basically liquid left, right? So that shows up. I've seen the supporting sexual function question before. Yeah, that's basically it. Also, what type of materials will we also expect this patient to need? What would we educate them about as far as, preventing leaks in the system or emptying the bag, keeping I's and O's, things of that nature. The use of fiber, and things of that nature. And I think that's about it. Yeah, I think that's about it. All right, next slide. And again, just reiterating, checking out to see what's normal, what's abnormal, complications, what we do to fix those complications, and of course the hernia, which is a big problem sometimes if there's a problem with the stoma. Next slide. All right, so this is a fantastic slide. I like everything that you have here. Is there anything else that I need to tell you about azorzabide that you haven't already put in here? First thing in the morning, good. Don't do double doses, good. Right, headaches are a sign that the medicine's working, yep. It's for angina, good. I think that's all I can, yeah, you got everything you need for this slide. Most of the questions are related to all of these points, and it's just a matter of recognizing the points based off of the patient's history. It'll say newly diagnosed or newly prescribed azorzabide, and that's where you know that you're going to be looking for the adverse signs and symptoms in the patient as your answer. And yeah, you've done a fantastic job with this one, so I have nothing further. Next slide. And again, with regard to calcitonin, everything that you need to know about calcitonin that's ever going to be a question is on this slide. I know there's not a teetotal ton, but again, there's not a whole heck of a lot to take home with this particular medication, so this is fantastic. And next slide. All right, so when we're talking about Tegretol, we have a couple of things that we need to worry about. Number one is Stevens-Johnson syndrome. It's the systematic peeling of the tissue layer by layer by layer, and it is systemic. If you ever want to never forget Stevens-Johnson syndrome, just give it an images lookup. All you need is like 2 and you're good. You won't forget that one. And you will know that this causes this reaction. Also, there's the caveat with the 14 days wait before starting to take an MAO or MAO inhibitor. Used to treat epilepsy, trigeminal neuralgia, good. Acute manic and mixed episodes of bipolar 1 disorder, perfect. Also Rett syndrome, also peripheral neuropathy. I don't think I read that. And yeah, that's basically it. I like that very much. So these are usually the pieces and parts you need to know regarding questions. Tegretol. I can't think of anything else that we need to be concerned about. I think everything is nice and even Steven in here. Yeah. And I think that is the end of our slides too, right? Yeah, perfect. All right, you guys did a fantastic job. We will continue to do this if it continues to help you. I know some of you guys have commented that just hearing my voice kind of makes things a little bit easier. While I'm incredibly flattered by that, I totally don't get it, But hey, if it works for you, cool. I will keep doing this if it makes you feel at ease, because that's what everyone should be feeling right about now, is at ease, because this is literally it. This is literally the last bit. You're at the end of the hilt, okay? The light is there. You just got to keep crawling through. You were literally right there. So fight, and fight hard, all right? If you need anything, send me text messages as usual. I love you all. I'm very proud of you all. And I hope things go well. Keep me updated, and I will talk to you later. Bye.